Thank you for joining us for the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded, and you can also enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type a question in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, our next impact seminar will take place on Tuesday, August 5th, with Dr. Patricia Franklin, professor and co-director of the Outcomes and Measurement Hub in the Department of Medical Social Sciences at Northwestern University. We also invite you to attend classes first conference on September 18th and 19th, and I will put the conference link in the chat. And with that, I will turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Hi, everyone. It's my distinct honor to be able to introduce Dr. Taj Mustapha. Mumtaz Taj Mustapha is an associate professor of internal medicine and pediatrics and the chief equity strategy officer at mHealth Fairview. I'm going to tell you a little bit about her background. She completed her undergrad at Stanford and then did her MD at UCSF, and then came here and trained in the combined internal medicine and pediatrics residency training program. And she also served there as the chief resident. She has served in a variety of roles, and as I went through this, so impressed. So she served as the clerkship director first for internal medicine, then has been the faculty advisor, as well as this associate program director for the combined Med-Peds residency program. Really has gave back in the way of teaching and education, director of clinical coaching and the lead for DEI in the clinical learning environment. She has really overall a passion for the development of individual and programmatic assessments, which we're going to hear a bit about, to promote inclusion and the development and implementation of theoretic frameworks and the assessments to reduce health disparities and to achieve health equity in healthcare. She's been notably recognized around sickle cell disease, in particular the Sickle Cell Health Equity Champion Award through the Sickle Cell Foundation through our local community. She's also an outstanding teacher. She's been honored with the Outstanding Faculty Educator Award in the Pediatrics Residency, the Educational Excellence Award in the Department of Medicine, the Distinguished Mentoring Award at UMMC, and then finally the Mullen Spector Truax Women's Leadership Award from the University of Minnesota. And so with that, please join me in welcoming Dr. Taj Mustapha.
Thank you so much, Genevieve. I'm sure if I listed your accolades, that would take the entire rest of the seminar. So thank you for that lovely introduction. And thank you for inviting me. I'm really excited to present to this community because I think there is such an opportunity as we look at our health systems and look at how we think about improvement, how we decide to measure and look at improvement, that in a way that we can really advance outstanding care for everyone and really advance health equity. So I'm going to begin by just talking a little bit about health disparities. I could give a whole talk just about health disparities, but there are a lot of those talks out there, and quite frankly, by people who are a lot more dynamic than myself. So given the mission of the learning health system, instead, I'm just going to give a brief overview of some of those health disparities, and then highlight what I'm hoping will be good information for really discussion today, but ongoing discussion, importantly, consideration as people think about crafting projects and moving them forward, and also action, both within the health system and within the university. I have no financial disclosures, and certainly nothing I'm going to talk about is off-label use. So I am going to talk about how best intentions, particularly in how we use and understand data and metrics, often fail to improve disparities, or worse, exacerbate them. Once we know and understand those pitfalls, we can address them directly in our research and project design and execution and get moving on a path towards health equity. But we need to understand and avoid those pitfalls actively. Okay, so I'd be remiss to not provide at least a couple of reference points in describing health disparities. And I know for a lot of you, this is exactly where your work lies, and this is very rudimentary, of course, but for others, this may be new information. So I'm sure that said, almost all of you have seen maps or graphs similar to this. It depicts the disparate impact of COVID on BIPOC communities. Illustrated in this map in particular is the burden on Black communities. Another disparity, which is gaining increasing sunlight, certainly in the popular press and slowly within health systems, are those that exist in maternal infant health. One of those disparities is infant mortality rate, which is over 2-fold higher for babies whose moms are Black compared to those whose moms are white. There's no shortage of graphs and maps showing disparities in health, and with few exceptions, the disparities show improved outcomes for white populations compared to Black and Indigenous populations in particular. Adults with hypertension, difficulty accessing care, overall life expectancy. There are still many more demonstrated disparities. As I said, just describing the disparities could be a talk in itself. There are disparities in cancer survival rates, in chronic disease burden, as well as morbidity and mortality from myriad infectious diseases, including rotavirus in children, hepatitis C in adults, pneumococcus in the elderly. So my point is, people have been describing this problem of healthcare, health outcome disparities for a long time. So why aren't we moving forward? How is it that public health and population science has been banging at the door of equity and we aren't really getting through? Well, the overarching answer is that it's really complex and hard and requires multiple institutions of power to prioritize equity, and not everyone is interested in equity. And that's true. There are multiple factors that contribute to health. If this may be, again, for those of you with a public health background, really familiar, but it's important if you're interested in improving equity, that you kind of understand the full cycle that contributes to health. So let's start in the yellow part of the cycle and move clockwise. The yellow represents the upstream contributes to health. So this represents the realm where history, policy, institutional power, and prejudice interact. For example, an upstream cause is discriminatory hiring practices or discriminatory enforcement of laws or policies, something like redlining. Next, the first green segment is living conditions. Using the example of redlining, you can see how upstream policies and discrimination can directly affect living conditions between populations. Redlining resulted in Black communities having categorically different access to living spaces, public parks, other services, more proximity to things like toxic waste, air pollution, as well as an increased burden of environmental toxin exposure in general. The next green section is about individual risk behaviors. But again, this is influenced by the factors that precede it. If you don't have a safe outdoor park to play in, you're going to be less likely to play outside and therefore more likely to engage in sedentary behaviors. While those risk behaviors are of course individual, they can't be divorced on a population level from the environmental contributors. Then the last green section is where health services come in. This is where we raise questions like who has access to care, where are clinics located, what insurance is accepted, what is the quality of care people receive once they come into the doors. The yellow portion of the cycle combined with the green portions are all together often described as the political and social determinants of health. The last green segment in maroon is the data we collect on health and healthcare outcomes. I'll be focusing on that last green hexagon in the maroon segment for the remainder of this talk, because this is where learning health systems have the power to interrupt the cycle of health inequity. I'm going to describe 3 key ideas in surveillance and evaluation that end up undermining well-intended efforts to improve equity in healthcare, and then finish by talking about the path forward. So the first factor, a flawed construct of race. This first idea is that medical research, including quality research, still largely applies a flawed construct of race. I'm going to spend more time on this example than the subsequent 2 because there's a bit more to unpack with this one. First, let's talk about the good intentions. Almost all of the intent involved in collecting race data in modern medical research, at least over the past 20, 30 years or so, involves a deliberate attempt to address oversights of the past. Race is collected to demonstrate diversity in sample populations and therefore bolster the argument regarding the general applicability of study results. Small, racially homogeneous, and geographically limited populations have notoriously been the source of poorly performing models, such as the original childhood growth charts based on the small cohort of white Midwestern children. Additionally, there's increased appetite to develop models that actually address health disparities, and a desire to figure out ways to do so at the individual patient care level. I'm going to come back to this point that the biomedical construct of care is based on a profession and discipline that intervenes at the individual level. In the patient care room in the clinic, we don't employ a public health framework. We employ a framework to improve individual patient outcomes. And that can mean a disconnect between public health framed research and the actual impact in the clinic. All right, so though I know I said I wasn't going to talk about all the history of medical inequities, I'm not, but I think it's important to understand medical science's history in order to understand why there is a flaw in how race is used when it comes to clinical practice. So rigorous study in medicine using the scientific method to test hypotheses is relatively new. In fact, most of the history of medicine, the practice of medicine, is actually muddled by attempts to find a scientific basis for sociologic phenomenon. The social science behind understanding human diversity in terms of race is actually much more recent than the pseudoscientific movement of eugenics. The eugenics movement started and persists by conflating an understanding of genetics and Mendelian inheritance with social categorizations such as race. If you're interested in the history of race in medicine, I do recommend reading Dorothy Roberts' book, Fatal Invention, or Angela Assini's book, Superior. Both of them cover this topic nicely. The research that continues to debunk race-based medicine and demonstrate human equality from a biological fitness standpoint is difficult for biomedical researchers to reconcile with the fact that different racial groups have different health outcomes. Biomedicine wants to explain everything using only a biomedical lens. And that's the problem. Because where we need to go is not an ignorance of social phenomena, but a proper consideration of them. Racism is real, but race cannot be used as a stand-in for clinically significant genetic variability or for anthropometric data. We need to marry social science research that seeks to understand racism along with other sociologic phenomenon with biomedical research and not confuse them for each other. To explain, I'm going to give you an example of how that confusion has and is playing out. So race is used as a biological construct across a multitude of clinical decision-making tools and guidelines, from how we dose transplant medications, estimations of cardiovascular risk, as a modifier in expected lung performance is calculated by a machine, and when we may decide to start colon cancer screening. And that's only a sample of the tools used every day in practice by healthcare providers that are built on population studies where race was used, but then extrapolated or analyzed as a biological construct. Until very recently, race was used as a modifier for estimating kidney function, and many places still use this flawed method. So that's the example I want to take a deeper look at. eGFR stands for estimated glomerular filtration rate. It's essentially a measure of kidney function, but it's only an estimate. Precisely measuring kidney function is really difficult and it's cost prohibitive to do with regularity, but clinicians need a way to quickly estimate it. And eGFR is performed on a basic everyday blood test called the basic metabolic profile. I bet most of you probably had a basic metabolic profile performed if you've ever had routine blood work. In addition to telling you something about the organ itself and when it might be failing, clinicians also use kidney function estimates to make a ton of other clinical decisions. Many drugs rely on kidney metabolism or excretion. So kidney function factors into the complex risk-benefit decisions that are made every day in medicine. The best intention here was to develop an accurate measure of kidney function. The study pictured was a landmark study that considered multiple variables known to be associated with kidney function, like sex, age, diagnosis of diabetes, blood pressure, and various serum electrolyte concentrations. They looked at a number of biological variables and race. And once the analyses were done, the data showed that the sample of people who were identified as Black in their study would have their kidney function underestimated in the model if race were excluded. By incorporating race, the estimation became more accurate. So we talked about how important an accurate yet easily obtainable measure of kidney function was, and the goal of the authors was to do just that, great intentions. What resulted were estimates that included a race adjustment where the eGFR calculation is multiplied by about 20% for patients identified as Black. Subsequent studies continue to refine this model. As late as 2021, they were looking at race. They said, hey, this study found this. Let's see if we can replicate it. And let's see if we can refine it. The result of all those models that use race in this way is that the final estimated GFR appeared as two numbers, one with and one without the race adjustment. One if Black, another if non-Black. It was up to the clinician to apply the appropriate number to individual patients, meaning a provider chooses which number to use based upon their understanding of a patient's race. So let's break down the problematic components here. First, what is race? So pictured here are the Aylmer twins. They're fraternal twins. In the small box, you can see a picture of the Aylmer family with all their siblings. You may have seen these twins before. They were on like the talk show circuit for a little bit because people were fascinated by the way in which they look different. So let's ask ourselves, do these twins have different heritage? If you drew a pedigree chart by race or ethnicity for their ancestors, would it look different? No, of course not, they're twins. But now think, if you just visually saw them alone in an exam room, say they're sick and confused, can't have a conversation with you, and you need to apply an estimated eGFR, one if Black and one if non-Black, which estimate would you use? And would you use the same one for each sister? Because what is race? Really simply, race is a categorization of humankind that shares certain distinctive physical traits. That's it. But to support slavery and racism, many countries enacted laws linking race to ancestry, giving rise to the notion of things like racial purity. And the idea that a person who looks white but has a Black grandparent or parent isn't in fact white, but instead is passing for white. Things like the one drop rule, which has absolutely nothing to do with genetic admixture. Literally, the math doesn't add up. But these legal definitions of race led to different environmental and social conditions for people based on race. And so that legacy of slavery and oppression then created different cultures within geographies based on race. So while race itself is just a phenotypic categorization, in racialized societies, it also has cultural meaning for an individual and likely affects their socioeconomic situation. And this is why there is a phenomenon of self-identified race, which is the race a person identifies with. These two siblings might share the same self-identified race. That said, because the nature of race is that it is based on a purely phenotypical categorization based on these social constructs, it's why it also remains scientifically accepted for a third party to assign race based on visual assessment. This is known as socially identified race, or sometimes as street race. Socially identified race is used in some of the most robust studies examining the role of bias in interpersonal communication. In most parts of the world, including the US, these two sisters have different socially identified races. It is very likely, and they have reported themselves, experiencing race differently and having categorically different experiences with racism. In the US, one would have the experience of being Black and the other is being white. So if race isn't biological, when we think about our study findings examining eGFR, why was there such a distinctly different curve for kidney function estimation by creatinine clearance between those who identified as Black and those who didn't? Well, biomedicine then turned to ancestry. And I don't want to dwell too much on this slide, but to point out the fact that the authors put a lot of work into trying to model both self-identified race and ancestry as potential modifiers. But note, they didn't look at the impact of any other social determinants of health. This model considered known biological modifiers of kidney function testing, and then race. Many people before me have talked about how race and ancestry aren't the same thing. And in this study, they would want to look at those variables separately. They were using the hypothesis that ancestry would somehow be a relevant biological construct for use in research. Let's break that down a little bit, right? Shouldn't ancestry improve genetic associations related to geographic origins? The answer to that depends in part on the outcome under prediction. We would expect genetic ancestry to have correlation with specific genetic adaptations that are beneficial in some geographies. The classic example is malaria and sickle cell trait. Malaria is found in specific geographies, and therefore sickle cell mutations are highly associated with ancestry, and ancestry offers less admixture of geographic origin than race. But there are only a few medically significant conditions that are a result of geographically associated pressures on populations. In fact, most population differences, I'll give you the example of the retention of lactase, which is the enzyme that allows people to digest cow's milk. All humans are born with it, but most people lose that enzyme in adulthood. But specific ancestral populations tend to retain functional lactase into adulthood. And these populations are associated with cultures that rely on cow's milk as an important source of nutrition. Importantly, those geographically associated genetic variations don't track by race. These graphs show neighbor joining trees generated by lining up individuals represented by lines based on genetic similarities. So the closer the line, the more genetic similarity. The graphic on the right shows the neighbor joining tree across 190 genetic polymorphisms. So as you can see, the lines cluster by old world geographic ancestry. Geographic ancestry isn't race, but it's often used to support the genetic basis of race. This type of genetic grouping has pretty much no utility in healthcare, which again is based on the delivery of care to individuals. The graphic on the right shows the complete lack of geographic ancestry correlation to genetic specificity of a clinically relevant gene. The takeaway here is that neither race nor ancestry are dependable biological constructs in clinical medicine. So defining race and why we're using it is not just a teleologic exercise. It's an essential step and necessary to address any of the myriad potential confounders related to social determinants of health, which are, as we already talked about, influenced by race. So outlined here are the particular pitfalls of the eGFR studies. Race was collected as a demographic variable. In many studies, it was never even specified to be self-identified or socially identified. Next, race was analyzed as a biomedical variable and further identified on a binary, Black, non-Black. Issues with overfitting were ignored. In one study, Black participants made up 31% of the development data set and only 14% of the validation data set. The authors did note that they had a smaller number of Black participants than non-Black participants in the validation set, so the estimates of accuracy may be less precise in Black persons. And they noted they had insufficient representation of racial and ethnic groups other than Black and white. And finally, they doubled down on a biomedical explanation for racial differences instead of exploring any social determinants of health that might allow for a more accurate model. Said another way, they committed the 3 cardinal errors that we need to avoid. So the errors in study design when it comes to race that are made over and over again. First is inconsistency of racial categorization. Are you looking at race as a proxy for enculturation, or are you looking at race as a proxy for the experience of everyday interpersonal racism and racial bias, or both? There is Venn diagram overlap here between socially identified race and self-identified race, but it's not a perfect overlap. And if you're not in control of data collection, you should at least investigate how the data was collected. Many data sets do represent self-identified race. However, others do not. Notably, for employment purposes, HR offices they are legally bound to assign race based on physical appearance if an employee declined to self-identify. So if you are pulling HR racial data, it will always be a mix of self-identified and socially identified race. This leads to the second error, which is generating appropriate hypotheses regarding results stratified by race. When you encounter differences in outcomes by race, the hypothesized etiologies must include the role of social and political determinants of health and/or racial discrimination or racial stress. We can't just leave it at this is different and there might be a biological reason why it's different, because that's a huge error. Using race as a proxy for biomedical differences such as genetics, anthropometric or anatomy, any of those. Genetic and anthropometric variation is vast within racial groups, such that race is a terrible proxy for these factors. If these factors may play a role in outcome, then those factors should be measured. If you don't have it available in your data set, then that's the next step, is to say, we don't know, but the most likely thing is we think we need to look at this. If multiple regression analysis shows that race is still a significant factor, even when considering multiple biomedical variables, then we need to start looking at the social determinants of health and even interpersonal racial discrimination. If we keep making these errors and don't actively avoid them, then what happens? Well, our best intentions to address health disparities in point of care healthcare delivery, they actually end up obfuscating and exacerbating inequity. Race-based medicine propagates the racist construct that population differences in health are due to biological racial differences. More insidiously, by using race as a biomedical construct, the research models don't expand to actually consider social determinants of health, which affects everyone. All right, that was a lot, I know. Second thing, unseen biases influence assessment results. So I'm going to switch to examination of another idea. And I think you recently talked about the idea of patient experience and understanding patient experience. So hopefully this will lend itself to that conversation. I know that in some improvement projects, we look at patient satisfaction surveys and think about using them to understand the experience of different populations, especially in response to improvement projects. So good intentions. Healthcare institutions care about how patients feel. They care about delivering a positive experience. They understand that clinician staff communication, interpersonal interactions matter. They don't want to use proxy measures. They want to hear directly from patients. All of that's great. What's the problem? Well, it doesn't work. Multiple population studies demonstrate lower overall trust of healthcare and a belief of receiving lower quality care among historically marginalized racial populations, particularly Black populations. The bar graph on the right shows data from the 2020 Kaiser Family Foundation nationwide poll, and it's representative of similar data across multiple other population studies. But let's contrast that with the study of patient satisfaction scores headlined in the bottom left corner. Consistent with almost all published satisfaction data from health systems, That study showed that patient satisfaction scores fail to show adverse disparities for Black patients. So why is there discordance? Well, there are likely two contributing factors. One has to do with access, but I think the more interesting one has to do with the type of questions asked and the way they're asked. These instruments norm to the patient's expectations of care. If you've been treated poorly and expect to be treated incredibly poorly, and instead you're just given average care, you might give incredibly high marks. The care you received literally exceeded your expectations. That doesn't mean your overall trust or your overall feeling about healthcare is good. You just expected much worse. Because we don't ask every patient every time, we also aren't capturing all the events of care. And because we don't ask specifically about feelings of discrimination or disrespect, we are likely not capturing the concerns that a lot of marginalized patients have about the care they're receiving. So we're not capturing disparities in care experience, but there is an additional problem with this data. Patients overall rate women and non-white physicians lower than white physicians, and those differences are exacerbated when accounting for quality of care, meaning that looking at care quality by examining things like diagnostic accuracy, timeliness of communication, appropriateness of care, adherence to best practice guidelines, and other quality metrics, as those metrics improve, so as a physician provides higher quality of care, their score goes up if they are white and male. However, if they are not white or not male, their scores either don't significantly change or may trend downward. So this can be hard for people to understand, but I think it's important to understand why that may be. And we can understand that by understanding expectations. So gendered expectations of performance persist across professional roles. We expect female physicians to be more empathetic than male physicians. We expect them to spend more time, be more relational. If they do those things, they aren't exceeding our expectations. They're just meeting them. If a male physician shows those behaviors, then that's exceptional. Additionally, we don't like women to be assertive or decisive, but often to provide excellent medical care, they need to be. This is why scores for women may decrease with higher quality because they get penalized for agentic traits. Similarly, racial biases influence our expectations of what it means to be a doctor. This is most pronounced on expectations of appearance, but also on things like accent, vernacular, and word choice. And that's at its most benign. At its worst, explicit racial biases influence patient satisfaction ratings of non-white providers. And I need to mention one more thing, which is it's important to know that diversity in the healthcare workforce leads to improved health equity, but it also leads to improved care overall. So we know that for marginalized populations, workforce diversity increases patient engagement, access, and appropriateness of care. For all patients, increased workforce diversity improves clinical decision-making and accuracy of diagnoses. It's important to know this to understand why patient experience metrics, as they are, can be problematic. So again, these metrics fail to capture important differences in patient population experiences, which can mask disparities. And an individual healthcare system can read that Kaiser Family Foundation study or any study talking about how Black and brown patients have terrible experiences in healthcare. And then what did they say? They say, well, let's look at our own data. And then they can say, well, they must not be talking about us because we're collecting data on experience and our results look great. So we must be doing a great job. Equally important, those metrics penalize women and non-white employees and can be incorporated in things like compensation plans and promotion considerations. And then they end up exacerbating disparities through worsening workforce inequities. All right, the last thing I'll talk about is being clear about what we're measuring and why we need to be clear about what we measure in order to promote equity. So again, good intentions. Healthcare systems should address health disparities. That's a great idea. Healthcare systems have robust amounts of data. They should collect and analyze that data and use it for improvement. And they should be encouraged to do so. Hospital scores should consider health equity measures. Reimbursement of care should consider equity. The massive healthcare industrial complex should incentivize systems to address healthcare disparities. all good intentions. But I'd like to hone in for a moment on the things that are commonly measured, the things that we could measure, and what they would mean. So a number of things that we measure for reporting requirements are health outcomes. In other words, they're reflections of the entirety of the health equity cycle. Things like mortality, readmissions, and disease incidence and disease control represent a combination of both the social determinants of health as well as the health care provided. It is cumulative. In other words, changing how we deliver care to different populations within our walls alone will not fully correct for differences in social determinants of health. And therefore, as long as those social determinants persist, we're going to continue to see population differences in these outcomes. Now, our health provision can reduce those disparities or widen them for sure. So of course we should aim for reducing them, but the healthcare delivery itself is just a small part of the entire cycle, and therefore is going to have a limited effect on these larger health outcomes. On the other hand, healthcare outcomes are wholly controlled by a healthcare system. These are differences in the actual care we provide to different populations. A great example is how we treat peripheral arterial disease or poor blood flow to limbs. In a large national VA-based study, Black patients were much more likely than their white counterparts, even when controlled for socioeconomic status and disease severity, to have their limbs amputated instead of less invasive procedures to restore blood flow and save their limbs. So you can imagine an amputation has significant implications for quality of life. Other clear healthcare outcomes are all the outcomes related to timeliness of care. Are there differences between populations in ER wait times? How long after presenting with a long bone fracture before you're given any pain medicine? When you present with chest pain, how long does it take for you to be evaluated for an MI? Those are some measures of timeliness that have demonstrated differences by race and gender in these large national studies. Those differences are a direct reflection of our healthcare delivery and something that we are wholly responsible for, and with directed resources could change. But when our reporting requirements incentivize equity metrics for health outcomes, they actually end up incentivizing and exacerbating inequity, because the easiest way for a system to improve their health equity numbers is to change the denominator. Systems that refuse to take Medicaid or public insurance, or just make it difficult for people with those insurances to access care, or just limit access in general, are a prime example of that tactic. Also, by not requiring equity analyses of healthcare outcome measures, we're not actually asking ourselves to look at the types of things we could actually directly impact. All right, so I'll end with the path forward, because I think that's important. And there's just a few things we need to think about. One is we need to overcome this philosophical barrier I outlined at the start. We need to name and understand it. The biomedical construct of a population is rooted in a biomedical approach. It's summarized by the question, what's wrong with the set of individuals? Do they share a mutation? Were they exposed to the same toxin? What's the simplest explanation for this complex set of symptoms? That is very different from a sociologic population, and racial groups are sociologic populations. So when we do medical research, we need to find a way to marry our biomedical approach with a robust sociologic one. A key factor when marrying this approach is a change from a race-based study design to a race-conscious one. We can continue to examine the role of race, but we need to do it with much more nuance and understanding of how race interacts with other pertinent sociologic variables. We need to deliberately use self-identified race when we care about effects that may be related to racial enculturation and socioeconomic stress. And we need to use socially identified race when we care about factors that we think may be influenced by personally mediated racism. Importantly, if it's relevant, we need to collect and stratify results by anthropometric and lifestyle data. There are 2 points here. The first is that we need to use available relevant biomedical data and collect additional necessary data. Too often, race is used as a proxy for lifestyle factors. For example, a few prominent UK studies that examined racial differences in diabetes and cardiovascular risk failed to collect data on pertinent lifestyle differences between, for example, Indian immigrants and their descendants and multi-generational Anglo-Saxons. While lifestyle choices may be associated with race, they are not inexorably tied to race, and unlike race, are modifiable. Without understanding how lifestyle factors affect risk, and by simply associating risk with race, all patients get disadvantaged. And the second point here is that racial differences are really poor proxies outside the context of the study population. As we already discussed, race is a poor proxy for ancestry. Additionally, race is a poor proxy for cultural differences as well. Oops, I just got a pop-up, excuse me. So the best example of race being a poor proxy is if you just look at what Asian race signifies and the diversity of languages, religions, cultural norms, diets that are consumed across various people who would be classified as Asian by race. It's not a good proxy for any of these other variables. And we need to separate how we use health outcome data and healthcare outcomes. Healthcare institutions still have a role in collecting health outcome data. I'm not saying that we don't, but that data needs to be mapped not to healthcare institutions, but to populations. And responsibility for improvement of that data has to be shared across sectors. That said, we really need to start devoting more energy to looking at healthcare disparities, because with directed resources and effort, a healthcare system could close gaps in healthcare disparities in a relatively short time frame. And finally, we need to understand the role that we all have in promoting health equity and actively breaking the cycle. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. And that requires moving obstacles to health, which certainly involves intervening at the level of social determinants of health. But individual healthcare institutions also have a role in breaking the cycle at every stage. And importantly, the way we look at data and how we choose to evaluate improvement, what metrics we track, all of that has a critical role in breaking the cycle of health inequity and promoting health equity. Thank you so much for your time. And I think hopefully we have a little time for questions and discussion.
Hi, wonderful. Thank you, Dr. Mustapha. That was fantastic. We have about 5 minutes for Q&A. I know we need to get you out of here early. So if you have questions or comments, please raise your hand, use the raise your hand feature, or type your question into the Q&A. Oh, goodness. Okay. We have Sheila said, Dr. Mustapha, thank you so much for highlighting the deficiencies in the current approach to measuring patient experience overall, and most importantly, for populations of color. The CLHSS tools that hospitals are required to use are inadequate as a means for truly eliciting patients' perceptions of care and service in the context of their biology, biography, and lived experiences. Do you have any thoughts about how we might get more meaningful feedback in a way that can be easily scaled for large health systems across multiple encounters? Keeping in mind that we are required by CMS to collect CLHSS data and already spent a great deal of money in human resources to make this happen.
Yeah, thank you so much for that comment. So I will say, I wish I could tell you right now I have magic and this is how we can do it super cheaply and efficiently, and I do not, but I think there's a few key components. One, it's not that patient experience data is useless. It is just not going to tell us about disparities, because if we don't have equal amounts of trust and access across populations, we are not going to get equivalent data through those surveys. So we need to know that, but there's still plenty of use to be had in those surveys, just not looking at disparities. So there are two things. One, we need to philosophically and in our systems understand how to use and value qualitative data. So we get a ton of data through patient experience calls, through community meetings, through our community engagement activities, through outreach activities with community as people are having conversations. Why did you come to this? Why aren't you engaged in our clinic? We get tons of information from people. We don't always do a great job of using that information because it can't appear nicely on a graph. So we need to get better at how we understand and process qualitative data. And I think that's the first step. I think a concurrent step that we have to take is, one, understand that lack of trust is a key reason for this disconnect, right? If people don't trust you're going to use their feedback for actual improvement, they're not going to give you hard feedback. I mean, we know this in student feedback populations. We know this ourselves when we complete surveys, right? If you don't think anything is going to change based on what you do, you don't bother. So that's why, right, also response rates to surveys are much lower for marginalized communities. If you don't think anything's going to happen, you're not going to do it. And we need to make a stronger effort, one, showing what we are doing with the data, actively soliciting that feedback in a pointed way from populations we want to hear from but are not hearing from. So we need to do work on that trust building and outreach, and we need to use the data we already have, which is qualitative. I hope that answers your question, Jill.
Thank you. We have time for one more question, and someone would like to know the names and the authors of the books you mentioned earlier in your presentation.
Oh, sorry. Dorothy Roberts, Fatal Invention, and then Angela Sahini. Oh, I think it's S-A-I-N-I. I'll email it to you, Genevieve. And the book is called Superior.
All right. Well, once again, thank you, Dr. Mustapha, for taking the time to present at the CLHSS Impact Seminar, and thank you all for attending. Again, in closing, please join us for our next seminar on September 5th at noon Central Standard Time, where we'll be joined by Dr. Patricia Franklin. And once again, please join us for our in-person conference on September 18th and 19th. And this concludes our presentation. See you next time.